Is this working? No. Yes? Can you guys hear me? Is it working? Okay, yeah. Okay, hi everyone. So obviously I'm not Zach. I'm one of your TAs, but Zach is fine. He just asked me to take over this lecture for today. It's going to be the last lecture, so I'm super excited to spend it with all of you. So yeah, we're going to be talking about neuropsychological disorders. We're going to cover a lot of different topics today, and I hope that the memes that I've added make it fun for all of you. That being said, I know that we will be covering some pretty serious stuff today, so if at any moment you feel like you want to leave the room just to take a moment to yourself, totally fine. Cool, let's get into it. All right, so starting off with schizophrenia, or actually, wait, I have a really cool pointer that I can use. Just talk amongst yourselves for like 5 minutes. Okay, back to schizophrenia. So Bleuler in 1911, he was a prominent cognitive psychologist, describes schizophrenia as a splitting of mental functions like thought disintegration. So schizophrenia accounts for approximately 30% of psychiatric admissions. And something that I want you all to note is that this is very different from multiple personality disorder, which we won't actually be covering. For worldwide prevalence, we're looking at about 1% worldwide, and your typical onset is going to be between 15 to 35. So don't get freaked out, but actually the age that you're at right now, especially for younger women, we're talking maybe 18 to 23, 25 is when you see a real spike in diagnosis. There's no major geographical trends. It happens to be, unfortunately, extremely overrepresented in unhoused communities, and it's often triggered by stress or major life adversity. So I don't know if you guys have seen A Beautiful Mind. It was actually did a pretty good job with representing symptoms such as paranoia. So let's get down to talking about what those symptoms actually look like. We have two main broad categories of symptoms, positive symptoms and negative symptoms. And something that I really want you guys to take away right now is that positive symptoms denote normal cognition. So you've got normal cognitive function plus these other things, such as hallucinations, which are false perceptions. You know, you can hear voices or you can feel strange bodily sensations. Delusions, which are these fixed false beliefs, and disorganized speech and behavior. On the other hand, you can also have someone experiencing negative symptoms. So this is when you actually begin to encounter deficits in normal cognition. And so this can be something like poverty of speech or thought, can be difficult for the person to string together spontaneous speech. Apathy, which is not just like, oh, I don't want to do anything today, but like a real lack of motivation or initiative. Social withdrawal, a tendency to self-isolate, and depression, so persistent low mood. Something else that you'll see in schizophrenia patients that have negative symptoms is what we call flat affect. So instead of speaking perhaps like you and I would with, you know, there's like normal changes in pitch to my voice, speaking really, really flatly. So as we talk about schizophrenia, I'm sure we might be wondering, are these hallucinations actually quote unquote real? What's going on in the brain when someone is having a hallucination? Yeah. Oh, you didn't have a question? Okay. Really depends on what you mean by real. But this study, I'm not sure when it was done. I can look that information up for y'all if you're really interested. But this study looked at patients, non-schizophrenic and schizophrenic, and looked at this, when the schizophrenic patients were reporting that they had a hallucination. And so this, who can tell me quick quiz, who can tell me what part of the brain this is here, where we're seeing patterns of activity? Yeah, temporal lobe. Good. So this person was probably experiencing an auditory hallucination. And what we can see here is that in the hallucinating patients, even in the absence of an external speech sound, so it was completely quiet in the scanning room, they did have patterns of activation in their temporal lobe. Whereas in healthy subjects, those patterns of activation are probably due to listening to the scanner or something else, but they aren't really correlated with having a hallucination. So what else do we know about schizophrenia in the brain? We're not really sure about the exact mechanisms, but there is a really strong heritable genetic component, about 70 to 80% heritable. There are a couple of different hypotheses. So one is this dopamine hypothesis, which basically says, okay, you've got hyperactive dopamine signaling, which can explain the positive symptoms that we talked about. Specifically looking at D2 receptor, although you guys don't really have to know that. And what evidence do we have for this? So the antipsychotic medications that we give to these patients specifically tend to be dopamine receptor antagonists. They block in some way or modulate the activity of dopamine receptors. If you see patients with schizophrenia taking illicit drugs such as amphetamine or cocaine, these are really, really catastrophic because they can actually worsen symptoms by upregulating dopamine. However, there is another hypothesis which takes a look at glutamate specifically. And so it's basically saying, okay, well, we might not have enough glutamate transmission in the brain, and that might account for some of both our positive and our negative symptoms, such as hallucination, which is a positive symptom, or a negative symptom being, for example, that flat affect or that apathy. It's also possible that GABA might be responsible for some of these symptoms as well. There's a lot of different interactions here. The most realistic one is that GABA, glutamate, and dopamine are all interacting together. And so here's just a picture of kind of different areas that we want to make sure we point out. And some of these you guys have already seen before. So with caudate nucleus, specifically dorsal striatum, we know that's implicated in movement and in motivation. VTA, you guys talked about when we looked at reward and reward processing. Substantia nigra, dopamine production. Prefrontal cortex, decision making, executive control. All of these areas are vastly affected by schizophrenia. So why and how do schizophrenics hallucinate in the first place? Not totally understood, but this figure is going to help us break it down a bit. So everything that you see here in the purple depicts reward regions, and the green depicts speech and hearing regions, and the red is spatial and sensory areas. Does everybody kind of understand that? Sounds good? Okay, cool. So these are all implicated in hallucinations. It can be that with reward processing regions, you can faultily attribute, let's say, a given stimulus to, you can mismatch stimuli essentially. With the speech and hearing regions of your brain, you can be processing perceptual inputs that might not really be there. And with the control, spatial, and motor areas, you may not be able to recognize that inner speech that you have is actually inner speech, if that makes sense. So that's a hypothesis for why hearing voices may actually be just a misattribution of inner speech. And you'll notice that all of these areas have a strong contribution of dopaminergic neurons. Are there any questions here? Yeah. Yeah. So that's a really good way to put it. It's kind of like alienating your own internal monologue, where it no longer becomes recognized as an internal monologue. Yeah, again, really hammering down on this point that it's most likely a combination of these hyper excitable auditory and language pathways, and then you have faulty executive processes to properly compensate. Something else to take note in schizophrenic patients is that there's this progressive loss of gray matter. And this happens over time, but it really begins most in adolescence. So well before the symptoms of schizophrenia really begin to show up. So we're measuring average annual loss here in percent, and we have boys and girls on the bottom. And then we're not given their age, but this is about probably, I would say, if not at time of diagnosis, maybe a couple months after diagnosis. Does anybody want to point out anything that they're noticing here about the differences between gray matter loss in boys and girls? It can just be anything if you feel like you've got something. And if not, that's totally fine. Yeah. Yeah, yeah. So there's some current research going on about this, about sex differences in schizophrenia. As of right now, I don't have anything super conclusive to tell you guys, but we might be hearing some exciting news about sex differences with this progressive loss of gray matter. Another hypothesis to explain why and how schizophrenia develops has to do with the abnormal neuronal migration hypothesis. So I know you guys talked about cortical layers and organization of neurons in those layers pretty early on in the course. And what this hypothesis basically puts out is that interneurons, which are really important for modulating communication between neurons, have been found to migrate to wrong layers of the cortex. It's like they're misplaced. And so what this eventually ends up leading to is an imbalance in excitation and inhibition. So this is actually a disruption of circuitry at the whole brain level. Yeah, so here we have an example of a healthy control individual versus an individual with schizophrenia. Returning back to that really strong heritable component, this is a pedigree, and it's examining a family that has both recurrent major depression, schizophrenia, and bipolar affective disorder. And we'll talk about this when we talk about bipolar disorder, but there's one gene, I'll show it to you later, it's D1SC specifically, that has been implicated in all three of these disorders. And there's some current research going on that talks about, well, why, if there's a gene that's responsible for, let's say, all three of these, bipolar, depression, and schizophrenia, why not develop gene therapies to target it more extensively? Or like, what's the evolutionary sense behind developing schizophrenia or bipolar disorder or depression? We can talk about that later when we get into bipolar disorder, but it's just a question to get you guys thinking about. Yeah, again, really strong example of gene environment interactions. It can be possible to, for example, have a family tree that looks like this, and let's say have relatives that you know that struggle with these disorders, but never actually develop a diagnosis on your own. All right, so let's get into mood disorders. Roughly 7 to 10% of people currently worldwide, nearly 20% of adults at any point in their life will struggle with a mood disorder. There are major, major, major comorbidities with other disorder. So some that we'll go through specifically today are major depressive disorder and bipolar disorder. And then seasonal affective disorder, just a quick point there is that it's cyclical depression, really, really common during the winter, but it can occur during the summer as well. Any questions here? Cool. Okay, so depression. I shouldn't laugh. Yeah, go ahead. Yeah. Yeah, so that's a really interesting question. I think I think there was some research that came out a couple years ago that actually looked at like cultural coping mechanisms for like countries such as like, you know, up in the global north that have those really, really long, harsh winters. And they actually found that you actually tend to see lower rates of SAD because people spend more time in community or like, you know, indoors. Um, you actually have worse rates of SAD in countries such as, well, actually in the US, because we have such like segmented seasons, if that makes sense. So it's possible to have like really vibrant summers and also really long, dreary winters. But yeah, really good question. Did I see somebody else's hand? No. Okay, good. Yeah, so these are some pretty sobering statistics here, but 3.8% of the global population currently struggles with depression, 5% of adults worldwide. It is actually the second leading cause of disability worldwide. So just take a moment to really take that in. This is more than like all cancers combined. So this is something that's really serious. It affects a lot of people. It tends to be more common in women, about 50% more common than men. But if we kind of begin to break down that statistic, there are some reasons as to why that might be the case, such as what's the cultural stigma for even reporting depression? What resources are there available to treat depression? Some symptoms include persistent low mood, anhedonia, which is an inability to feel pleasure, changes in sleep, appetite, and also sex drive. And specific areas of dysfunction that we'll take a look at are the hippocampus, the subgenal cingulate cortex, and the amygdala. Something else to know is that with a diagnosis of depression or with experiencing depression, you actually raise your risk for a lot of other things, such as vulnerability to chronic disease, diabetes, arthritis, asthma. Relapse from addictions is common, and also the stigma of even dealing with a disease like this can also impact your ability to get support. There are a few specific correlates that I really want you guys to remember and grab onto. One of them being this signature hypometabolism throughout the cortex overall. So this is from a PET scan, and we're measuring glucose uptake. On the right, we've got a healthy participant brain, and you can see that there's a lot of activity basically overall across the cortex. But on the right, we've got the brain of a depressed participant. What are some things that you notice? We've got a lot less activity overall across the cortex. Something else when we look at in the brains of depressed patients is the atrophy of the hippocampus. So this is actually reflected as a volume loss in the hippocampus. You are literally physically losing tissue. Here we're looking at another PET scan, and it's a PET scan combined with another type of scan where we're looking at cortical not cortical thickness, sorry, but thickness of the hippocampus. And what you can see is that this would be the brain of our normal control patient, and this would be the brain of our depressed patient. And everything that you see here in the blue is loss. The good thing is that these structural changes to the brain are reversible with treatment. Any questions here? Yeah. Sorry, the slides for this one? Oh, yeah. I'll upload them after class. Yeah. Any other questions? We'll move on. So how do we actually treat depression? SSRIs are usually our first line of defense. They stand for selective serotonin reuptake inhibitors. And so if we look here at the level of the synapse, what our SSRI is going to do is after you've had your neurotransmitter released into the synapse and it's ready to be reuptaken, the medication will actually block this uptake transporter such that the neurotransmitter will stay here in the synapse and we'll be able to excite the postsynaptic cell over and over and over again. SNRIs, which are kind of like a second line of defense mechanism, stand for selective norepinephrine reuptake inhibitors, and they actually affect both serotonin and norepinephrine uptake. So this is an example of how an SNRI might work, where you have both the serotonin transporter and the noradrenaline reuptake transporter affected. It's important to note that these new medications, I'm sure that you guys might have heard of some other medications such as MAOIs or tricyclics. And really, it's the SSRIs and the SNRIs that are the more recent medications. It's important to note that these aren't necessarily more effective than our older medications. The side effects are just a lot less worse. And for here, you guys don't need to know like all the specifics of like, oh, it's this specific type of transporter that's affected. I think Zach and I just want you to know the basics of like, okay, SSRIs and SNRIs are the most effective medications that we have so far. So focusing on serotonin specifically, how many of you guys have heard of the serotonin hypothesis of depression? That depression is caused by too little serotonin. Raise your hands. Okay. It's actually it's a pretty damning hypothesis because it's not true. There hasn't been any, there was a recent meta-analysis done in 2022 and a couple others done in 2019, and none of those found any link between low levels of serotonin in the brain and clinical depression as we know it. And the way that it actually came about was through some misreporting of some scientific work earlier on, but we're gonna go ahead and break down that hypothesis. So this figure up here is plotting out number of stressful life events and then probability of developing a major depressive episode. And so this doesn't have to do with the actual like physical amount of serotonin that you have being made or circulating around in your brain at any given moment. This has to do with the way that the allele for your serotonin transporter, 5-HT, the way that it's actually like shaped, so to speak. So you can have three combinations of this allele. You can have two short alleles, you can have a short and a long allele, and you can have two long alleles. So if we're looking here with the short and the red line, this is basically saying that like, well, if you've got at one stressful life event or at two stressful life events, your risk of developing a major depressive episode is raised by having those two short alleles. That is a genetic risk. For individuals who have both long alleles, you can get up to 2 or 3 or 4 number of stressful life events, and you have a lowered risk overall of developing a major depressive episode. And for individuals who have a short allele and a long allele, your risk is kind of in the middle. However, if you have, let's say, both short alleles, which I don't even know how you would know right now. You'd have to go get genetically tested. If you have both short alleles, this is not a death sentence per se. Remember, all of these genetic underpinnings of these disorders have to interact with their environments. And so if you, for example, if you're living well, even if you have, let's say, 4 number of stressful life events, but you're here within this range of, let's say, comfort in life, and that can look like socioeconomic status, that can look like diet, that can look like exercise, that can look like community support. It's possible to reach up to like so many numbers of stressful life events, multiple stressful life events, and still never face a risk above, let's say, 30% of developing a major depressive episode. So it's something just to keep in mind. And here's another figure explaining how those SSRIs actually work. So we can see that we've got our serotonin being released from our presynaptic vesicle. It's here exciting and binding to the receptors on the postsynaptic neuron. And then this SSRI will come in and will block the reuptake channel. And so this serotonin will be able to just stay in that synapse and keep on exciting the receptors. All right, so I told you guys we would get into debunking the serotonin hypothesis. What's one reason? So I guess I'll frame it this way. If a lack of serotonin in the brain was really the cause for depression, what would instantly raising the amount of serotonin in your brain do? If it's just like, okay, you don't have enough serotonin, now we're dumping your brain full of serotonin, what would you see? Would you see people getting better, getting worse, or staying the same? Yeah, you'd see them getting better. But SSRIs take weeks to months to work. So that already kind of clues us in to like, okay, just physically raising the levels of serotonin in your brain is not really sufficient to ameliorate depression overall. Other medications that don't target serotonin are equally effective. So I made a mistake in the last slide. I said that SNRIs target serotonin as well. They don't. They only target norepinephrine. So SNRIs and MAOIs, which target monoamines, you guys don't need to know that, those are equally effective as SSRIs. And then this guy, Moncrief, and his colleagues, that was that meta-analysis I mentioned earlier, in 2022, analyzed over 360 studies, and they found absolutely no convincing evidence at all for depression being associated with low levels of serotonin. So what are some other biological underpinnings that we can point to for causing depression? Gene and environment interactions. I know that's beating a dead horse, but it really is true. There's some high heritability component to this as well. If we remember that we go all the way back to that pedigree that I showed you when we were talking about schizophrenia. And recently, people have been talking a lot about BDNF, brain-derived neurotrophic factor. It's a neuronal growth factor. It helps modulate plasticity, axon travel throughout the brain. And so people are thinking that dysfunction in BDNF might be implicated in depression. Something else is widespread inflammation throughout the brain and dysfunction of the HPA axis, but we're going to get into that a couple of slides later. Any questions here? Yeah. Why do SSRIs still work then? Yeah, great question. I mean, we're not totally throwing out the role of serotonin. It's not like, okay, well, serotonin isn't impacted. Like we see no immediate change. Guess it doesn't matter. Raising serotonin levels does still help us treat depression, but it's not like the most effective treatment overall. Yeah, I wish I had a better answer. It's still something that a lot of people are really interested in researching. So talking about treatment-resistant depression, there are a couple of new treatments that have people really excited. And one of those is repetitive transcranial magnetic stimulation. How many of you guys have heard about that? Cool. Okay. WashU is actually, I think, has one of the like foremost national centers on TMS right now. And so we're just going to go over the basics, but essentially you bring someone into the clinic, and then you attach this magnetic coil. It's this TMS coil, and you create a local magnetic field. And we're going to be stimulating the dorsolateral prefrontal cortex because it's thought to be hypoactive in depression. Anyone want to take a stab as to like why you think, like why are we choosing DLPFC to stimulate? Why not anywhere else? Yeah. Increased reward is what you said? Okay, interesting. Anybody else got any other ideas? Yeah, yeah, really good. So essentially, after, yeah, we're going to place the coil over the, oh wait, did everybody hear Alex's answer, by the way, about DLPFC, why we're specifically choosing that region? Cool. So he's basically saying that like DLPFC is really important for being able to coordinate like long-term beneficial choices for oneself. And like you said in the back, it's also really important for learning how to adequately place reward valuation on things. So that's why we've chosen this region. So after placing the coil and creating this local magnetic field, you're going to interrupt cellular signaling by basically pulsing specific wavelengths of electricity. And a given session will probably last 30 to 40 minutes. And this works incredibly, incredibly well. Like people who have been struggling with depression for years will have one session of TMS and will be able to really feel a substantial improvement. And patients will usually come for a course of a couple of sessions and will also do talk therapy on the side or may also be taking medications. So it's a really exciting new therapeutic technique. Something else that really works for depression, even though we don't know why, is ECT, electroconvulsive therapy. This is currently facing some challenges though, because it's seen as, it's what you would call, I mean, it's seen as barbaric. And so, because this is what you would colloquially term as like shock therapy, but it works really, really well. And in a clinical setting, it's safe and effective for patients. Did I see someone's hand up for a question? No. Okay. Something else that works is ketamine. So I think WashU is also developing a lot of new, I think they just developed like a center for this, I'm not sure. But here we're looking at a given patient's brain. This is measuring neuronal growth. And here we are at baseline, so before being administered ketamine, and here we are 24 hours post ketamine administration. And everything that you see in red is going to be growth. And what you can see is that this patient has had an extensive amount of growth just 24 hours after receiving therapy. Self-reports from patients say that they can feel better within 40 minutes, which is insane if you think about it. And ketamine, we know, specifically targets GABA, glutamate, and NMDA receptors. It's also commonly used in combination with other therapies. Lastly, we also have deep brain stimulation, DBS. And this is where electrodes are surgically implanted around the cingulate cortex. And instead of increasing activity, they actually reduce activity. All right. Anybody got any questions for this before I move on? Yeah. Yeah, great question. So with ketamine, I think I've heard that one session, so this is a therapy where you don't have to come back, let's say like every 2 weeks or every month or something. Like one session can last you for a couple of months. It's also used a lot with PTSD patients. Let's see, I think I've heard that it can last, yeah, a couple of months, and that this growth, it's not like you're sliding back. It's not like you're regressing to a state of hypometabolism. It's like once you get the brain like really kicked into gear again by using any one of these therapies, you don't see a slide back. You can see with more of these therapies, with medication, with talk therapy combined, you can really begin to see improvement towards growth. All right, so moving on to bipolar disorder. This is, yeah. Yeah, so this is meant by like new synaptic connections. This can also be like actual like new growth of neurons in the brain as well. So that's what that means. You can it's like a small technical, we can talk about it after class. Yes. Okay. So with bipolar disorder, we're looking at 2.6% of the US population facing this disorder. That accounts to about 5.7 million Americans. And the typical age of onset is 17 to 21. No sex differences and no differences across any racial or class groups. Like schizophrenia, a really strong heritable component, about 80%. And with bipolar disorder, I want you guys to really grasp on to the two distinct behavioral and emotional states. So one of those is mania. And the conditions for like a manic episode to be met is that it has to last more than 1 week. You have this elevated and euphoric mood, an increased like need or propensity for risk taking, a decreased need for sleep, increased sex drive, rapid speech, and racing thoughts. And then on the other side of that, there's depressive episodes, which we've already covered a little bit of, but this will be low mood, anhedonia, and ability to feel pleasure. And you may develop delusions at this time. And so this figure here is just showing us the typical, let's say, course of someone with bipolar disorder over time. So could be that manic episode lasts for about a week, and then a major depressive episode lasts for 2 weeks, and then perhaps there's a period of feeling normal, so euthymic mood for maybe, let's say, a month, but then it's possible to plunge back into a major depressive episode for about a week again, and then a manic episode for another week. So it's really characterized by this cycling through highs and lows. How do we treat bipolar disorder? Lithium was discovered accidentally, I think all the way back in like the 1800s. And as of now, it is the single most effective treatment that we have for BPD. We actually don't even know how it works, though. That mechanism is entirely unknown. Um, well, not entirely, but there's still a couple of things that we're really trying to tease out there. Anti-epileptic drugs, which antagonize dopamine, also work. And that's because you're suppressing excessive neuronal activity. Antidepressants actually don't work for patients and may raise the chance of starting a manic episode. Does anybody have any idea of why they think that is? Yeah. Did I see your hand in the back there? Yeah. No, you're good. Okay, perfect. Yeah, so there's still a lot of development into treatment as well, but as of now, standard of care is lithium. And we know that lithium specifically targets the NMDA receptors in the brain, and it also promotes GABAergic neurotransmission. So there are a couple of sobering outcomes that I want us to take into account when we talk about BPD. 15 to 20% of patients will die by suicide, but nearly 50% will attempt. BPD, I think I said that it was depression, but it's actually BPD. BPD is responsible for more years of life lost to disability than all forms of cancer combined. And again, we've got this gene, the DISC1 gene, linked to both schizophrenia and BPD. So what's the overlap between the two? I'm sure you're wondering. There are some noticeable patterns of cortical thinning across your VLFC on both left and right, your anterior insula on both left and right, and on dorsomedial prefrontal cortex. So think about what's really being affected here. Can some people shout out what are some things that are being affected here when you target these areas? Yeah. Hmm. Yeah. Someone shout out one more. Don't all talk at once. That's all right. We'll move on. I'm sure we'll get it later. So DISC1 codes for protein growth, migration of neurons, and also axonal connections. And cingulate cortex, which isn't pictured here, is also affected, which is pretty interesting because we talked about that a little bit in depression. So here I just really want you guys to focus on how intertwined these three different disorders are: schizophrenia, bipolar, and depression. Notice that there are some similarities, notice that there are some differences as well, and also notice the differences in genetic risk. All right, so let's talk about phobias and anxiety disorders. 20 to 25% of the world's population will face some kind of phobia or anxiety disorder. Some examples here can be panic disorder, which is characterized by panic attacks, these intense minute-long episodes where you feel dread. Some people may feel as if they're going to die. Generalized anxiety disorder, which is kind of sustained tension and anxiety. Post-traumatic stress disorder, and obsessive compulsive disorder. We won't really have time to go over all of these, but this is just kind of a bulleted list of the disorders that are under this family. So there are a couple of different reasons why we think that these disorders may come to light. One is over-responsiveness of the amygdala, specifically in generalized anxiety disorder, phobia, and PTSD. The other is frontal influences, so anterior cingulate cortex in OCD specifically, and dysregulation of the hypothalamus pituitary adrenal axis. All right, so this looks really gross, I know, but bear with me. This figure here on the left, you guys don't need to know all of that. That's just there if you're interested. What I really want you all to focus is this figure here. And I'm actually going to go to the board and draw it out for a minute. Can everybody see if I work on this board here? Yeah, perfect. All right. So here's your brain. And here is, let's say that's your thalamus and your hypothalamus. All right, but here's your hypothalamus. And here, I won't draw it out super specifically, but you've got your pituitary gland. Anybody know what the pituitary gland does? Yes. Yes, good job. Okay. Sorry, my handwriting is awful. And then we're actually going to move out of the brain entirely, and we're going to go to your kidney. Does anybody know what sits right on top of your kidney? Yeah, your adrenal gland. Great. Okay, so let's say you've got a stressful life event. I'm just going to write stress. Sure, we're all pretty familiar with that. Got a stressful life event. Your hypothalamus will begin producing CRH, that corticotrophin releasing hormone. It'll send that message along to your pituitary gland, and your pituitary gland will start producing ACTH, adrenal corticotrophic releasing hormone. That will then get sent along to your adrenal gland, where you'll begin to produce cortisol. Now, does anybody know if cortisol is pro-inflammatory or anti-inflammatory? And it's okay if you don't know. Cortisol is actually anti-inflammatory. So here's where things really begin to get interesting. Do you guys remember how we talked really briefly about how brain-wide inflammation can be implicated in depression and schizophrenia and bipolar disorder? So the more stress your brain is faced with, goes through all of this loop, creates more and more cortisol, right? But you actually have a dysfunction in this pathway. And so you end up with lower, sure you can see it there, you end up with lower cortisol levels. And if cortisol is an anti-inflammatory hormone, what does this mean? If you have low levels of an anti-inflammatory hormone, you actually end up increasing levels of inflammation. And so what I want you guys to take away here, besides like the actual pathway, and I also forgot to mention that production of production of cortisol will send negative feedback all the way back up to the hypothalamus and anterior pituitary. What I want you guys to take away here is that there's a really interesting interaction between the nervous system and the immune system. So it's this decrease in cortisol and in its anti-inflammatory properties that will raise inflammation in the nervous system overall. And that in and of itself, that inflammation is a stress signal for the brain. So you're stuck in this cycle of stress. Any questions here? You guys don't need to know all of the specifics. If you're interested in, like, if you really want to know what you need to know for the exam, you can come and talk to me, but it's going to be like, we're going to cover this very lightly. I just thought it would be interesting for y'all. Okay, so now talking about substance abuse disorders. Yeah, so casual use is certainly possible. But it's really when we get into dependency, that's the problem. Does anybody want to shout out what what's the difference between dependency and tolerance? So dependency is actually when you build up like a physical let's say, reliance on the drug, but you don't yet need to increase your dose to get the same effects from the drug. However, tolerance is really when you see the beginning of a growing, you need a larger and larger dose of the drug to get the same effect that you once were able to elicit when you first started the drug. Withdrawal is a complicated but ultimately very nasty set of symptoms. And when I say nasty, I mean that it feels absolutely awful to go through withdrawal. It's a set of symptoms that occur when you're facing complete abstinence from a drug. And then you can also face other physical or psychological problems that are associated when you develop an addiction. What are some mechanisms? It's ultimately complicated, as all of these things often are, but we're seeing an upregulation of reward circuitry. So this is going to be your insula, your striatum, your VTA, your orbitofrontal cortex. And you're seeing a downregulation of regions involved in executive control. So these would be those dorsal prefrontal regions. Something else is that drug context will amplify your hippocampus and your amygdala. And so what I mean by that is that your hippocampus and your amygdala, which are very important for contextual binding, can become sensitized to locations and to people that are associated with drug use. So this is actually why people who are in recovery are often told to try and avoid the places that they used to buy or engage in drug use, or the people that they used to engage in drug use with, because if they were to, let's say, go back to an old place where they did drugs or see a person, the hippocampus and the amygdala would actually, you would see a higher response elicited from that kind of encounter, if that makes sense. Any questions here? Nope, all good. So this is actually a little bit of the work that I do. I was able to go and present at SFN earlier this year. I work specifically with opioid-induced respiratory depression. So I thought it'd be fun for you guys if I walked you through some quick data that I worked on. This won't be on the test, but this is basically, we looked at being able to antagonize a specific type of opioid receptor called a mu opioid receptor at the NTS, which is a site within the brainstem, which controls breathing and heart rate. And we found that basically if you block this receptor and you give fentanyl, and then you give, you block this receptor and you give fentanyl and you wait before giving naloxone or naloxone methionide, which are both opioid reversal agents, you actually see that animals are able to recover a lot faster whenever you block this receptor. So that's pretty cool. We are hopefully, not just the lab that I work in, but a lot of other labs, we're hopefully a lot closer to making sure that people with opioid use disorders don't face high overdose rates. Lastly, psychopathy or sociopathy. Not really clinically meaningful. So these if you were going to formally diagnose someone, the diagnosis itself would be antisocial personality disorder. We see a prevalence of 1% or less in the United States. And some of the characteristics are antisocial behavior, impaired empathy or remorse, a propensity to lie, poor inhibition, egotistical, selfish thinking, and a propensity for crime. What are some of the causes? Again, we're not really sure. We can maybe chalk this up to a hypoactive prefrontal cortex, but a hyperactive amygdala. If you guys remember Phineas Gage, remember that drastic change in personality that happened when he had the spike go through his eye. Also a strong environmental factor. A lot of, I guess, serial killers that have come forward and that have been formally diagnosed with antisocial personality disorder have described really rough and cruel upbringings. So it's definitely something to take into consideration. So we're probably going to end a little bit early today, but just wanted to thank you guys so much. Yeah, Zach is at a talk right now, but before the course is over, if you guys wouldn't mind filling out the course evals, it'll literally just take 5 minutes, maybe 7, but that's not so bad. 5 minutes. And this was the last lecture of the semester and my last time TAing ever. So I had so much fun. being able to teach you guys and seeing you during office hours and exam review sessions. So yeah, it's been a great semester. Other things is that I will send out an announcement soon about the exam review session. I know the last 2 times we've gone overtime, so this time I'm going to be a lot more realistic. If you come, it will probably be 2 hours total. And that's just to make sure that we can get through all of the material, get through all of your questions, go through it as in-depth as possible. And it'll probably be during the 11th in this room during the afternoon. I'll send out an announcement this week. And then other than that, good luck on your final exams and have a great break. And if you guys have any questions or anything, feel free to come up to me.